So the first case is aspiration. This is a 72-year-old male, and he presented with a cystic mass in the kidney, and it was suspect to be a sensory granulomatous pyelonephritis. And the clinician do the aspiration of the cystic mass in the kidney. Okay. So on low power, we already see that it's a very necrotic debris, and when we go to high power, we see mostly massive necrosis, and we 奇怪了，为什么这个会这样呢？诶，是有人动过了吗？
是昨天有用，没错。
昨天是谁动成这样子？嗯？
可是昨天好像用起来也还好啊。
不对，它整个焦距的头跑掉了。
会不会是物镜松掉？
没有。为什么嘞？为什么会动到目镜？没有啊。你们昨天为什么会动到目镜？嗯？好。Okay, so I see a lot of necrosis, and also there's a lot of keratinized, a typical keratinized cell. So in this background with a lot of keratinized cell, we always think about, could it be a squamous cell carcinoma? And in the acute, in the sensory granulomatous pyelonephritis, there's usually a situation causing obstruction of the urinary tract. It most commonly is due to the stone, and it causes the accumulation of urine in the renal pelvis and then induce inflammation. And because of the stone, it can induce some squamous metaplasia under very severe inflammation. So for this case, it is suspect to be squamous cell carcinoma, suspect to be particularly urothelial carcinoma with squamous differentiation. However, because of the clinical picture, it's thinking about sensory granulomatous pyelonephritis, and we are uncertain if there is a stone in there for a long time or not. So we'd better be more conservative. So our diagnosis is suspicious, and we see massive necrosis, and we cannot exclude the possibility of high-grade urothelial carcinoma with squamous differentiation. So this is the cell block preparation. So we see a lot of keratin with this lamination in this specimen. So it's kind of unusual. I've only seen one time with severe chronic pyelonephritis inducing the squamous cell carcinoma within the renal pelvis. I've only seen it one time. So this is kind of unusual, and we don't have a lot of well-preserved cells, so so it's better for us to just using the suspicious diagnosis. However, we already remind the clinician that there's a possibility there's a cancer with squamous differentiation. So this is a relatively unusual case. So the next specimen is coming from a pleural effusion of the patient with past history of breast invasive ductal carcinoma. So on low power, we see a lot of cells, mostly in loosely cohesive cluster. And when we go to high power, the cells show marked polymorphism. So you see very big cells with a typical change. Some smaller cells in the background also show a typical nuclear feature. So this is positive for carcinoma, compatible with metastatic cancer from the breast. The next case is also a pleura effusion specimen. So we see quite proteinaceous background. And in this background, we do see a couple individual cells with enlarged nucleus and prominent nucleolus with a plasmacytoid, like an eccentric nuclear pattern. And some of the cytoplasm, you see some yellow material, suggests that it is a mucin. So it seems to be like a fully differentiated adenocarcinoma with a signaling cell or mucinous feature. However, the nuclear polymorphism is more striking comparing to the usual gastric signaling cell carcinoma that we most common to see. And so the patient had a past history of cholangiocarcinoma. So this is adenocarcinoma, and due to the patient's past history, this is compatible with cholangio with poorly differentiation and metastasized to the above the diaphragm to the pleura cavity. The next specimen is also coming from a patient with breast cancer. This is pleura effusion specimen. So in this specimen, the fixation is not so good. However, we do see three-dimensional cluster with this glandular shape, and the cell do show striking nuclear atypia with these like square shaped nucleus instead of smooth and round. So this is metastatic carcinoma compatible with the past history of breast cancer. Okay, so then we have two cases of pleura effusion. This patient had the past history of ovarian high-grade serous carcinoma, and this is the pleura effusion specimen. So in this specimen, mostly are tumor cells. So this is not difficult to identify because majority of the cells show these high-grade nuclear atypia, three-dimensional architecture. The nuclear chromatin pattern is vesicular with prominent nucleolus. So this is high-grade adeno compatible with high-grade serous carcinoma. The next specimen, the patient had a past history of triple-MT malignant mixed Mullerian malignant tumor. So this is carcinosarcoma of the gynecologic tract. And in this specimen, the cell for some reason is not very well preserved. It is you see a lot of crushing artifact, but you can still see that the nucleus show hyperchromasia and arranging in a glandular pattern. And we do not see any sarcomatous element. It is very rare to have metastatic sarcoma in the pleura cavity or in any body cavity. So when we take a look of the cell block preparation of the same case, it is much well preserved. So you see all of the tumor cells are actually glandular cell. So our diagnosis is adenocarcinoma, but it is compatible with metastatic glandular component from the patient's past history of triple-MT. So the next case is final aspiration from the thyroid. So this is the direct smear. So you see a lot of drying artifact. So on low power, we see larger fragment, cohesive fragment. However, in the background, we do not see any colloid. So this is relatively unusual for thyroid aspiration if it is a benign case. So we go to higher power. The nuclear does show some TPR with overlapping, and nuclear orientation is not very well organized. Then we need to see if we can find some more typical nuclear feature. So because the case shows severe drying artifacts, so it is uncertain if this is a true nuclear inclusion, but we did not see a very well preserved membrane around this inclusion. But here it looks like a true inclusion over here. So we start to see some PTC nuclear feature as well as some multinucleated giant cell. So we have the architecture pattern, which is larger sheets and overlapping and with a papillary type of growth pattern. We see some nuclear DPR, including the pseudo inclusion. And we also see multinucleated giant cell, and this is coming from the thyroid. So I think this is definite for the malignant case for papillary thyroid carcinoma. The next case is also a thyroid aspiration. This is the liquid-based preparation. So in this preparation on low power, again, we do not see a lot of colloid in the background. However, we do see a couple scattered these small follicular architecture. It looks like a microfollicular pattern. So when we go to higher power, some of these cells do show a little bit of oncocytic change with more abundant cytoplasm and granularity. And we don't have a lot of cells. So again, it seems to be a small follicular architecture. So that is pretty much what we have. So for this case, I think it's reasonable that we call it AUS with architecture TPR due to scant colloid and the scant cellularity with majority of the cells arranged in these micro follicular pattern. So this is AUS with architecture TPR. So the next case is a lung aspiration. The patient had a past history of endometrial clear cell carcinoma. This is a direct smear. So in this specimen, we see high-grade nuclear feature with a glandular architecture. So this is a high-grade adenocarcinoma. And we do see some vacuole in the cytoplasm, so it can be compatible with the past history of the clear cell carcinoma. But not all of the cells that presented here show prominent clear cell change. So it can be because of the resistant disease and with the treatment effect and inducing a more high-grade nuclear change or cell change. So the next specimen is from the breast aspiration. This is from our branch hospital, so we don't have the liquid base. This is the direct smear of a breast aspiration. On low power, we see high cellularity. So we see a lot of the cells, and majority of the cells have these loosely cohesive pattern, and even with some single cell. So when you see loosely cohesive pattern and single cell, we are alert that it can be a carcinoma, particularly invasive ductal carcinoma. So usually in the breast, the carcinoma cell would be more discohesive. So when we go to higher power, the cell does have, the cell do have abundant cytoplasm, and which show a more like a dense or granular feature. So this is likely due to apocrine metaplasia. So sometimes for the apocrine metaplasia, you will see some nuclear atypia similar to the oncocyte Herzl cell, and you can see enlarged nucleus, prominent nucleolus, and abundant granular cytoplasm. However, if it's a benign apocrine lesion, usually it won't be that discohesive. So we were thinking about invasive carcinoma, and we go to the area with more preserved nuclear feature. Indeed, the cell is quite big and with some nucleolus. However, in the background, we do see scattered, like a smaller, more condensed cell, seems to be myoepithelial, which suggests that even with these cell proliferation, we do see some spindle oval, more condensed cells, suggest that there are still some myoepithelial cell in the background, like this negative nuclear. So this is likely that the lesion are still preserved some myoepithelial cells, suggests that it might be a DCIS, the invasive ductal carcinoma in situ. So I think our diagnosis for this case, I think we can call it suspicious because of this cancer carcinoma pattern. However, due to the background, we still see quite some myoepithelial cells, so we cannot exclude the possibility of DCIS. So we call these suspicious and rule out DCIS. So the next specimen again is a thyroid aspiration, and it is also a direct smear. So this case with more like a good fixation, it's better fixation. So you can see on low power, you see papillary branch, and we see high cellularity and some micro fibrovascular core here with detached follicular cell in the background. And we don't see colloid. We only see very, very dense colloid, so-called bubblegum colloid over here. So on the in the background, it looks like a papillary thyroid carcinoma. So we just need to go to higher power and to check if there is any nuclear feature that we are comfortable to call it PTC. So when we go to higher power, indeed the cells show enlarged nuclear, some ground glass chromatin pattern, and a lot of cells showing these oval shape. I think it is not very difficult to find the pseudo inclusion. We still need to. So here you do see some grooves as well. So overall, I think majority of the cells show prominent nuclear feature of PTC. So here you also see some grooves and some overlapping. We don't have dots here. So let's take one more look to see if we can find pseudo inclusion somewhere. Take some time, so I think we can find pseudo inclusion, but we didn't dot it, so it's not easy to find it right away. So this is pretty good for the PTC nuclear pattern. You see these coffee bean like cell, a lot of them show this ground glass nuclear chromatin pattern. So this is positive for papillary thyroid carcinoma. So the next case is from the pancreas EUS guided biopsy aspiration. For this case, in the background, we do see some benign mucosal cells. So this is benign. However, right next to it, we already start to see some necrosis. So this is necrosis. This is necrotic debris. And then we go to places to check if there is more prominent nuclear atypia. So here we do see these overlapping glandular cell with prominent nuclear atypia, as well as background necrosis. So this is adenocarcinoma from the pancreas. The next specimen is also a PTC aspiration. So again, this is more bloody, but we do not see a colloid in the background. We see a lot of layer sheets of follicular cells. So here we do see a multinucleated giant cell over here. And when we go to higher power of these follicular cells, we see the cell showing nuclear groove. So this is PTC. A lot of blood in the background, so it's a little bit difficult to see through. But these nuclears are also showing some atypia. So this is PTC. So finally, let's move to some pap smear. So the first case is a 59-year-old female. So relatively elder. There were a couple, like a cell cluster showing borderline feature with slightly enlarged nucleus, slightly increased NC ratio with a vague coelocytic pattern. And there were quite some field showing this feature. So this is compatible with a low CO, with ASCUS, and it does not fulfill the diagnosis of the low CO yet, because we didn't see hyperchromasia and we didn't see like unequivocal coelocytic feature. So the next case is also interesting. Also a middle-aged female, showing focal change with suggesting it's a low CO, but the cellularity and the quality does not fulfill the definite diagnostic criteria. So it is likely that we can call these ASCUS. However, in the background, there are some very interesting cells. This power, you can already see the cell is pretty hyperchromatic. Okay, so you see these hyperchromatic cells. The cell has interesting shape, but it's quite some cytoplasm. The cytoplasm is not very dense, so it's a little bit difficult to tell if it is a squamous cell or it is not a squamous cell. So we can go to the other focus. So again, we see these cells with hyperchromatic nuclear feature comparing to the adjacent intermediate cells. However, you can appreciate that this cell looks more like a glandular cell instead of the squamous cell based on the cytoplasmic feature. So you have some glandular cells with hyperchromatic nuclear feature and with some atypia. And here, this is a little bit more difficult. This looks a little bit like metaplastic, immature metaplastic cells. When you start to see the cell nuclear size is increased, you definitely see some hyperchromasia, and the arrangement is a little bit strange. And there seems to be a little bit increase of NC ratio. The cytoplasm is getting more dense. So you were thinking about, could it be ASCUS high? Could it be squamous lesion occur at the metaplastic region, which is most likely a T-zone. However, when you take a closer look, this is cilia. This is cilia, right? And you can appreciate there's a very thin terminal bar here with some like a filamentous material. So this is tubometaplasia. So we don't need to call these Asker's height, right? This is a tubometaplasia. And so again, tubometaplasia is a great mimicker, particularly for high CO, because it can show some unequivocal hyperchromatic nuclear feature. So again here, you see this is actually a honeycombing pattern for the glandular cell. So this is not increased NC ratio. This is not a high CO. Okay, so this is honeycombing, and with hyperchromasia. But when you search along this string, you can find some cell with definite cilia. Actually, here you can like faintly appreciate that's a cilia over here. Okay, so this is the advantage for direct smear, conventional smear. So based on a lot of senior cytopathologists' experience, they find the glandular lesion is much easier to interpret in the direct smear comparing to the liquid-based cytology. Because for the liquid-based cytology, you don't have the anatomic information that the group of cells are actually together. They were all distributed evenly around the entire smear. However, in the direct smear, you have the anatomic information along with the sense string of the smear direction. So this is Asker's, and in the background we do see these hyperchromatic cells, but these are actually tubometaplasia. Okay. So we call these Asker's. We don't need to call these high CO or Asker's high. So the next case, the patient already received surgery. So she's a 74-year-old female, and she received total hysterectomy due to endometrial adenocarcinoma. So this is a follow-up smear. So first thing that we know, the patient is not a screening patient for cervical cancer. She is a patient for follow-up of the prior cancer diagnosis. So here we do see high-grade adenocarcinoma. So this is compatible with the recurrence of the patient's prior endometrial adenocarcinoma. So then we also have some precursor diagnosis. So this is another case. So for this case, again, you can tell from the background it's possibly a middle-aged female, like the prior case. However, this is the unequivocal low CO pattern that you see by nucleation, a very sharp contour of these clearing spaces. This is a definite oncocytic change. So you see definite oncocytic change and enlarged nucleus. Usually the nucleus is much larger comparing to the adjacent intermediate cells and some hyperchromatic features. So this is a low CO, definite low CO, okay? So the next case is 51-year-old female, so similar age. We have a lot of cell overlapping in the background. So for this case, in this tight cluster, you can appreciate that indeed there are some coilosity change. The nuclear show marked hyperchromatic chromatin pattern. However, overall, you can tell that the nuclear polymorphism is like exceeding the prior case that we diagnosed as low CO, right? So we have more cells, we have more hyperchromasia, and some of the cells are actually showing increase of NC ratio and getting to the superficial cells. So we are suspecting that it can already reach the high CO status. So with the combined low CO and high CO feature, we will call these CIN2. So for CIN2 cases, there were usually more lesional cell in the background. And the degrees of nuclear TPI is exceeding the usual low CO that we just see. So the case is signed out as CIN2 because of a lot of like a low CO cluster, and some even show increase of NC ratio. It's a little bit difficult to see through because most of the cell cluster are arranged in a very tight cluster. However, the hyperchromatic feature is very striking. So here we do see these are possibly low CO, but there is one cells over here with a possible very high NC ratio. And again, these are all like a cell with viral change. So the disease burden is quite high. Okay, so this is likely a CIN2 high CO case. Finally, there's a 52-year-old female presented with heavy mens. So in the background, we do see some old blood, and the squamous cell looks quite okay. So in this background, we do not see any precursor lesion in the squamous cell. However, we start to identify some of these glandular cells in the background. The cell actually doesn't show striking a TPI. It is very tight, degenerated. So this very tight cluster of glandular cells are usually coming from the endometrium. And in the background, we only see some old blood. We don't even see the degenerative, like a debris, endometrium debris like material. For in this case, I think we can just call it AGC. That's enough. We don't have to call this favor neoplasm because the nuclear feature is not very atypical, and we didn't see the degenerative debris. So here is a typical phagocytosis cells. So this suggests that it's a glandular cell and likely coming from the endometrium. But the background is pretty clean. It's only some old blood, but we didn't see debris. So this is okay that we just call it AGC. Okay, so that's all the case for today.